And here we go. Welcome everybody to The Big Idea. I'm Dr. Jeffrey Hanna here at Blair Chiropractic. I've got another case review for you here today. This is a gentleman who I have consulted with who has been previously diagnosed with cervical instability. He's had various treatments, headaches, he gets dizziness, he feels sense of nausea, just lots of ongoing issues, and trying to figure out a little bit more and understand what's the nature of his condition? Most importantly, what can he do about it? So I'm going to go through the images here at his request where we can go into this in a little bit more detail, but also where hopefully this information is available for other people who might be dealing with the same kinds of things, maybe been to lots of different doctors, specialists, lots of different opinions about what needs to be done, or not sure where to even begin. So hopefully this video is going to be useful for you. If you do, always make sure you click that like, subscribe button. If for no reason other so that the algorithm finds it, other people can find this information. And if you do want more information, you can also check out some of the other videos that we have on this channel. Let's jump into it. Now, as I'm going through all of these pictures, I don't expect everybody to be expert at looking at x-rays or MRIs or anything like that. I mean, I'm still learning a whole bunch of this stuff as we're going along. But there are a few subtle signs that, especially if you're dealing with these kinds of symptoms, these kinds of issues, things that you can be asking your provider, hey, what do you think about this? They might say, oh yeah, that could be a significant factor. They may also say, oh no, I'm not convinced by that. But these are the kinds of questions that at least deserve further investigation. And even if you put it into Google, even if you chat GPT it, you may not find all of the answers, because we always have to look at it like you are a human being first, try to put all of these little pieces together. So first thing we've got here are this gentleman's flexion and extension x-rays. Now, as you can see, first and foremost here, he has previously had a lower cervical fusion. In other words, he's been dealing with issues for quite a long period of time. He'd had the original procedure. It helped with many of the symptoms, but unfortunately now he's starting to get more of them. And this is one of the things with neck surgery. Neck surgery, there is a time and a place when we need it. When we're starting to deal with compressed nerves or loss of feeling, loss of strength in the hands or other parts of the body, and you can see a disc that is impinging on either the cord or on a nerve root, yeah, you're going to need surgery. But one of the things that we always need to be aware about is that if a person has neck surgery, that the motion that would have occurred at that area, it no longer exists. And what will characteristically happen is that the joints just below and above that, they're going to have to start to make up, and they're going to be moving a little bit more than they were supposed to in the beginning. And over a period of time, that can lead to instability or to issues in those areas. Very, very common, not only in the cervical spine, but also the lumbar spine. People have fusion of the L5-S1 segment. It's not uncommon that some years later, they're going to be starting to have issues at L4 and L5. And then L3 and L4. So, very important. Number one, take care of your body as much as you can. But life happens to all of us. So if a person has had fusion, all the more reason then why you need to be on top of taking care of your neck, taking care of your low back, getting physical movement, getting exercise, having adjustments when and where it is appropriate to do so to protect those areas of weakness. So he'd had the previous surgeries as we see right here. And the reason that he was having flexion extension views was to see if there was going to be instability of the additional segments, in this particular case going slightly above. What we would be looking at on these views, and the easiest way to detect it, is by looking at the back of the vertebra right through here. So all of the vertebrae, they essentially should kind of stack on top of each other, where the back parts are going to be in alignment. And that's going to be whether going forward or going backward. And I wanted to point out on his particular images here that what you might notice at the level of C2 right here, relative to C3, that the C2 is kind of tripping forward just a little bit right here. And conversely, when he's going backward, the C3 is tripping backward just a little bit like this here. Now, does this mean that he has cervical instability? No, in fact, he doesn't. Because if you want to be, or if you are dealing with true blue instability of these joints, when you go forward and you go backward, again, they're supposed to move a little bit, but it's when you see excessive movement where that forward plus that backward misalignment exceeds 3.5 millimeters, that's when you're dealing with the true instability. So even though there's this slight forward movement here, it's about 1 millimeter or 2. When he goes backward, it's fine. At the C3, when he goes backward, it goes back maybe 1 millimeter. But when he goes forward, it doesn't shift at all. So he doesn't have instability at the C2 or the C3 in this particular case. That's good. So we just ruled out one of the potential areas where, yeah, there's a little bit of movement, but by itself, that doesn't quite explain what's what. Now, I don't have his particular film because it was relatively low resolution. I didn't show it in this one. He does, however, have a bit of instability between C1 and C2. And I've got a couple little models here where I can kind of illustrate that concept here for you. So when you are tilting your head side to side like this, the C1 and the C2 pretty much should not move at all. But on his images, what I was able to see was that there was slight little movement like this when he tips his head this way, and slight movement like that. So what that means is it means that there is excessive motion of the ligaments right through this area here that are not as strong as they should. And this, unfortunately, can be a very, very tricky area to get to. Number one, it's on the inside of the spinal canal. So this is not an area that you can get to with normal injections, whether it would be cortisone for just pain reduction, whether it would be prolotherapy or PRP to strengthen those ligaments. It means then, okay, you've got to look at the adjacent areas to make sure that things are moving the way that they should, so that at very least it can take the tension out of that area so that things can be starting to feel and function a bit better. So he does have a little bit of instability of that area, but we're going to look at some of the other factors that he has going on that might be a little bit, unfortunately, difficult to treat from the standard injections model, but where there may be other signs where there is a bit of misalignment that could be responsible for some of the issues he has going on. Now, I also have on this particular slide pointing out this yellow area, or yellow arrow, where I'm pointing at his teeth. I don't think that the teeth are the issue in his particular case. For a lot of people, dental issues, TMJ issues though, they are what contribute to this excessive mobility at C1 and C2. That area is overcompensating, weirdly enough, for an issue at the jaw. He doesn't have that, but the reason that I'm pointing it out here, I don't know what these fillings are made of. That's what all that bright white is. But what I do want to make a comment on for a lot of people, amalgam fillings and or root canals. Amalgam fillings, they're made of mercury. This can be neurotoxic and can slowly leach into the blood and into the brain over a long period of time. And mercury, it's got an affinity for 3 organs: the adrenal glands, the thyroid glands, and the brain itself. You've got the normal connective tissue that's going to be protecting around the brain like this. What heavy metal exposure does is it can cause that to start to become leaky. That can start to promote inflammation everywhere in the body, but also the brain. And the inflammation over a period of time can lead to central sensitization, where the normal threshold that it takes for nerves to fire starts to go down. So it is the wind that is fueling the fire. So it doesn't mean that all people with amalgam fillings are going to be having issues like this, but it is a risk factor that I at least want to mention. In some people, especially if you're dealing with a whole bunch of metabolic issues, so digestion, hormone imbalances, I never rule out potential impact of silver fillings. Same goes with root canals. Root canals are dead tissue staying in the body. Over a long period of time, that can, in some people, be a risk factor that leads toward sickness, autoimmune conditions, different kinds of problems like that. I don't see signs of root canals in here because you can actually see it on the image. But again, it doesn't create the instability, but what it can do is it can amplify the effects if a person has that in their body. So very important that you work on nutrition and also detoxing to remove inflammation so that even if there is some physical or structural issue going on, it's not going to be quite as severe in your overall case presentation. But let's get back to the physical side of the equation and the things now that are showing up on his MR and also his CT scans. Again, I do not expect you to be expert at all of these things, but let me draw your attention to this little circle right here with these little bits and pieces that you'll see off to the side, and then this white-ish opening with this dark thing in the middle. What we're looking at is essentially cross-section at this level of the spine. So C1, C2. So the little peg in the middle, that's going to be the tip of the C2 vertebra right here. These things off to the side, that's where C1 is sitting atop of the C2. And then the spot that you're seeing in the middle, that is the spinal cord with the cerebrospinal fluid around it. So this is just for your orientation about where we're at. And what I'm going to draw your attention to, yellow is going to be the left side, pink is going to be the right side, because that's the way that MRs are presented. It's as if looking upward at somebody. I'm going to draw your attention to this black oval opening right through here. This is the internal jugular vein. It is the primary drainage pathway for blood from the head back down to the heart. And here we have, from a slightly out more to the side perspective, this dark shadow right here that's following its normal course. This black spots that you're seeing right here, so that little guy there, that little guy there, that corresponds with the tip, so the sideways tip like this of the C1 transverse process, a little bump that you feel on the side of your neck. And you can see that this pathway is pretty open. But when we look at the right side, you'd see that it's a lot smaller right in this area here. And from the sideways projection, you can see it starts coming down, and then there is a narrowing, aka a stenosis, as it's coming down like this. Not uncommon that people are going to have asymmetries of their veins, where one of them, just how they were born, one of them is bigger than the other side. However, when you see on an MR where there's a point of constriction, it's thicker here, and it's narrow at one pinpoint spot, that is evidence that's saying, hey, there's a point of constriction. Something mechanically is obstructing drainage of blood from the head. And what's interesting about the veins in the neck and in the head, they don't have valves. So normal veins elsewhere in the body, they have little valves so that as blood is flowing, let's say from your leg back up to your heart, it goes like this, and there are valves that prevent it from flowing backward. The head and the neck don't have that. So if there is ever a point of constriction, it means that blood can start to pool up inside the head, and it can start to disrupt circulation on the inside. It can cause a person to be feeling very floaty, foggy, headache, pressure, dizziness, lots and lots of different things like that. So I do see some evidence where there would be some kind of mechanical constriction in this particular area at the level of the C1 transverse process. So We already know from his x-rays, again, the images that I didn't have here for you, that there is something that's going on at the level of C1 and C2. And now we're seeing that the C1 is having some kind of vascular impact to the head. But there's also a little bit more than that that's going on this gentleman's particular MRs. And I have to comment that this is a phenomenon that I never really fully appreciated until just recently. And I am seeing it so much more commonly in people where especially they are having issues in the lower part of their neck, and the MRI report comes back saying that everything looks pretty much normal. I would agree here that I don't see signs of overt cord compression or friction or indentation or rubbing. I don't see anything like that. But I am seeing signs of what's called a CSF obstruction. So the white stuff that you see right here, this is the cerebrospinal fluid. This dark thing that you're seeing right here, this is the spinal cord right here. And you'll notice lots of space up in the top, but as you start going down, there's not much space for that fluid to flow. The emerging research is saying that whether you're dealing with issues of the brain or if you're dealing issues with the cord itself, of course, you don't want to see direct compression of things. However, if you are seeing that there is not enough room for that fluid to flow, that represents a point of turbulence. And people then can start getting symptoms associated with that area. And the MRI comes back as saying completely normal when no, this is not actually normal. So to illustrate, not just from the front view or from the side view, because you can't diagnose these things just from one view, but we look at it from its 90% angle. So here we would have basically at this level, the level of C4, here's the vertebra. Here's the white stuff, so there's cerebrospinal fluid, and here is the cord. The cord should be sitting right in the middle. It is sitting a little bit closer to the very back of the area. But then if you go down just that little bit lower, this slice right here, you'll notice that instead of it being bright white, well, white-ish, like it is over here, now we're seeing it's kind of muffled. It's gray. Oftentimes, this is considered to be nothing more than a metallic artifact related to, of course, having surgical implants there. But no, this actually represents where there is localized turbulence of that flow. So if things are not flowing on the inside the right way, this number one can be a pain generator, but number two, this can cause a person to feel dizzy or like things are swooshing or swaying around in their body here. And this can be honestly a little bit tricky again because he's already had surgery in these areas. So a second surgical procedure there is not going to work. At best, what you can hope for is that you're working and looking to see is there something going on at the adjacent areas so that you can preserve that flow, preserve that function as much as humanly possible. But as for what I think this gentleman's primary issue is, I think that it's showing up here on this particular scan. So now we're looking at a CT scan. So orienting you, so base of the skull is right here. Here's the neck. There are those fusions. Here is the spinal canal. Again, there's lots of space in the spinal canal, but just because there's space doesn't mean you still can't have fluid flow. But what I was drawn to when I was seeing this, and you might have to zoom in a little bit here where my mouse cursor is. I put the pink arrow here, but it's kind of obscuring a little bit. Do you see how there is this white-ish shadow right here? It's very, very thin, but it's there. And I'll comment that it shouldn't be there. And then we came to that cross section right here. Do you see that little loopity thing? Right there. So this corresponds with a very important ligament in the body. It's called the Transverse Atlantal ligament. So I'll bust open the little models here again. So the purpose of that ligament is to prevent this from happening with the C1, C2. It straps across the back. It is the strongest ligament in the upper neck. And if it is ever damaged, that's the guy that can start to lead to excessive movement right through here. The fact then that we can see this white stuff means that there's calcium deposition in that particular ligament. Why would that happen? Calcification happens in the body when you've had damage to ligamentous or even vascular structures, and it's laying down more calcium in order to protect that particular area. So I look at this and could say, all right, most likely this person has had some kind of damage in this area right here. And I'm also seeing where you also have some ligamentous damage, or excuse me, some ligamentous calcification occurring in this area right here. And this is what's known as the posterior longitudinal ligament. This is also something that is known, I didn't make up the name, its old name used to be what's called Japanese disease. It would seem to show up more in people of Japanese origin. The exact reason we don't know. It seems to have something to do with genetic susceptibility, but also a factor of previous physical injury. Body laying down little bits of calcium to support damaged ligamentous structures. So in some ways, it's a good thing because the alternative is going to be much worse. But the trade-off of that over a period of time is that instead of that ligament having the normal flexibility, the strength and flexibility that it should have, now it's going to become more rigid. And with the rigidity, this is like having a pebble in your shoe that creates a little bit of friction in this area because your spinal cord is actually meant to oscillate up and down, usually about 3 millimeters at any adjacent segment in the neck, or about a total of 1 centimeter total motion. Now, the upper neck is a little bit different. It should really only move about 1 millimeter total because you don't want to have where things are oscillating too terribly much. He doesn't have those particular kinds of MR studies, but I'm looking at this and thinking, okay, is this actually the source of that mechanical irritation? Because the ligaments also have nerve supplies. If then there's something that is affecting their function, such as a calcification buildup, this by itself can be the source of pain. Again, you need to make sure that things are moving the right way, but as much as we don't like to have to be having certain types of painkillers and whatnot, this typically isn't a condition where just doing injections or even just doing chiropractic work, it's not going to make that calcium reabsorb. So to a certain degree, a person might need anti-inflammatory medication, analgesic, so pain medication, to better manage their symptoms, to enhance, to improve their quality of life. Now, it doesn't mean you should ever become dependent on these things because, again, you still need to make sure that things are physically moving the way that it should. But if you're dealing with a pebble in your shoe, but it's on the inside in a space that is not accessible via surgery, we unfortunately may not have too many more options beyond that. So I think that in terms of especially the symptoms that this gentleman is describing, that this is the number one most important factor that he has going on here, this calcification of the transverse atlantal ligament. Now, as far as what can be done, like I said, you can't make the calcification go away, but you do want to make sure in the safest and most precise manner possible that the upper neck is moving the way that it should be. Do you remember that MR slide that I showed you? There was that irritation on the left side of the internal jugular vein. What I've got right here for you, this would be a cross section now of the base of the skull. These areas right here, those are the two joints on the base of the skull. This here is the opening where the spinal cord would be resting here. But I want you to pay attention to these white slips that you see right here. So you see only a little bit on the right, but you see a little bit more on the left. This is a common thing that we're going to be seeing on CT scans. And what it suggests as one possible, I'm not saying this is a guarantee, but one possible explanation is that what you are seeing is the top-down view like this because of a C1 misalignment, where that vertebra has misaligned like this. As a consequence, its upper rim instead of it being neutral compared to the opposite side, has actually gone up a little bit like that. And that, over a period of time, could be producing some of the mechanical irritation of the internal jugular vein. It can also be what's producing some of the tension at the C1, C2 area, because that area will compensate for this. And that can lead to ligament stretching over a period of time. Now, I must caution you about this, that is not a pathognomonic finding. And the reason for that, number one, is if you're having a traditional CT, it's done lying down. This CT was done lying down. So if a person's head is off center and they're lying just a little bit crooked, it could be an artifact of head position. In addition to that, some people, the base of their skull is not actually perfectly symmetrical. It is where the joints, one side is a little bit longer and the other side is a little bit shorter. And as a consequence, the normal resting position of that C1 actually is tipped up a little bit toward that side. So this could actually be nothing more than this person's head position. This could also be nothing more than a reflection of this person's anatomy. But it nevertheless, if you see this, at the very least, it demands further investigation, because this could be a sign of the very type of misalignment that would help him out. It's one of the reasons why an upright cone beam scan is particularly useful. So this is a CBCT, so cone beam computed tomography, but it's actually more akin to a cone beam, or if you would, a 3D X-ray, because this is very low dose radiation. It's not like a traditional CT scan at all. But what you do is you take out the potential for the asymmetries in the head position, and then you see it you see it for what it truly is. But you see this on your scans. At the very least, it requires a little bit more look. And this last one right here that I have for you, this one might be evidence about what the most important factor that can be addressed and can be done is. So we're looking at that same that same CT slice, but I've actually taken two slices here. One of them at the very base of the skull, and then the other one down at the level of C2. So you'd be looking at, I'll kind of try to trace it for you here, and I put them so that all the structures are directly where they would be on this person live. So here would be the opening of the skull, and yes, it is supposed to be bigger like that. So you're thinking, oh my God, it looks like the back of the vertebra is all the way back here. No, that is normal. It's normal that the base of the skull is bigger than the C2. So it's coming down like this, and then you'll notice this, well, I'll point at this opening right here, and then this pointy thing here in the back. So we're looking essentially at I'll do it like this, base of C2 like this. So here's the opening where the canal would be, and then this here, the pointy thing, that's going to be the C2 spinous process. Now, there is a lot of an issue right here, because if you're looking at the base of the opening of the skull here, and that tip thing of the C2, that should be in alignment right through here. But instead, what we're seeing is that there is a huge amount of rotation toward the right side over here. So we saw on the MR scans that there was mechanical irritation at the level of C1 on the right of that internal jugular vein. And now what we're seeing is we're seeing C2 rotation to that same direction. What that suggests is that there is some type of mechanical misalignment that's drawing the whole unit across like this. That can start to produce a lot of torsional stress that doesn't appear on an MR. It's a functional disrelationship where you're looking, how are the bones actually sitting relative to the soft tissue structures, because you know by proxy where they should be. That should not be so. Now, what its exact origin is, I can't see that on these particular scans. This is why we would recommend doing further study. So either a DAX, so a digital articular X-ray, where you can see what's the exact relationship of the vertebra at C1, at C2, C3, and so forth, down to C5, because again, C5 and below for him, they're fused. There's not too much we can do about that. But what this is all pointing toward is that something mechanically ain't right. And if something's been sitting and locked, essentially not moving in the right position over a long period of time, this can be a major source of pain generation. In the same way that if I was just poking you in the hand like this, I do that once or twice, it's not going to hurt you too bad. But if I'm doing that thousands and thousands of times, it's eventually going to form a bruise and it's going to become very sensitive. That can be a pain generator right there. So as far as recommendation here, I'm not going to recommend care at this point because we need further testing to find out, okay, is there something that's going on? Because we know that there is a little bit of ligament laxity at C1 and C2. Does that mean then that a person should never get physical therapy? They should never get chiropractic? They should never get any of these treatments? In his particular case, if it was severe enough, we would say, no, you need surgical fusion. But he's not at that kind of level. He would still be at the point where it can be managed conservatively. Now, what that looks like from a physical therapy standpoint means being very precise with the head movements and the exercises that you're doing to rehabilitate this area. From a chiropractic standpoint, it means, okay, a spinal manipulation like a twist or a crack is probably not going to be a good idea, and it means being very precise, gentle, and making sure that any impulse would use no more than the force that you would use to click a pen, and that the vectors, the way that those adjustments need to be designed in his particular case, are going to allow C2 to come back closer to its center and allow C1 to come back toward its center where we saw it agitating at the internal jugular vein. So there's a few possibilities for this gentleman going forward. In another video down the track, I'll give you a bit of an update, but just wanted to go through some of the imaging findings here again that all point toward this mechanical irritation factor, some of the things that we can help with, some of the things that we may not be able to, but that ultimately, again, go toward helping people get a better quality of life. So thank you guys for watching the video. I do hope that you stuck around to the end there because a lot of pieces with that, I know. And when it comes to this kind of stuff, as much as I wish that I could say, yep, here is the one root cause, here's the one and only thing that you need to do, vast majority of people, especially when dealing with complex issues like this, it's a combination of this piece plus this piece plus this piece that usually means that you're going to need a variety of different approaches: chiropractic, physical therapy, massage, acupuncture, myofascial therapy, surgery, musculoskeletal medicine, usually a combination of things. But when you combine them and see each of these little pieces for what they are, it helps you out so that you know you're not chasing just the one magic silver bullet, but that there's a lot of things that can be done, a lot of things that you're going to need to do, but that ultimately go toward improving your overall quality of life. So again, if you did like this video here, please click that like and subscribe button because, again, it helps other people find this information. And please feel free to share this video with other people you think would be interested or need this kind of information as well. If you want some more information about the type of work that we do, you can check out our clinic website, clearchirospokane.com. You can also check out some of the other videos that we have here where we talk about a few other conditions related to this area of the spine. So thank you guys for watching. I hope you have a wonderful day. This is Dr. Jeffrey Hanna at Clear Chiropractic. Get well, live well, stay well.